This episode is brought to you by the Fempower Health Chronic Pelvic Pain channel. And if you're not subscribed and want to learn more about chronic pelvic pain, make sure to subscribe where you listen to podcasts. You can search for Fempower Health Chronic Pelvic Pain channel or click the link in the show notes. And if you're interested in perimenopause and menopause, we also have a dedicated channel for that. Search for Fempower Health Perimenopause Menopause channel to explore more.
I can say 99% of the patients do not know how to use their diaphragm. If we understand the connection between respiratory diaphragm and pelvic diaphragm, you see why eventually it will create problems in the pelvic floor.
Welcome to Fempower Health. This is Georgie. Today I'm joined by Katalin Kapoor, a seasoned physical therapist with over 25 years of experience specializing in scoliosis, kyphosis, and pelvic floor therapy. In this episode, we dive deep into how scoliosis and postural dysfunctions can affect pelvic health, a connection many women may not realize. So for those of you listening and you've got urinary incontinence, bowel issues, GI issues, this may be just the episode for you. And as you know, if you've been listening to Fempower Health, pelvic health is so crucial, and there are a lot of surprising causes that we may not consider. So today it's all about scoliosis. Katalin shares how proper assessment and treatment can relieve the pain that you may be experiencing and prevent long-term issues. Katalin, thank you so much for joining me on the Fempower Health Podcast. It was so lovely to run into you at a recent local event here in Westchester County in New York. And I always love meeting people who have expertise on the pelvic health area, because the more I interview all of you, the more I'm learning how little we as women know about this space, but why it's so important to be aware. So today we're going to be talking about how scoliosis impacts our pelvic health. And that was something I learned when we had first met. So before we dive in, why don't you give us an introduction about yourself and we'll take it from there.
Okay. Well, thank you so much for having me. It's very exciting. Yeah, so I'm a physical therapist. I'm originally from Hungary, and I moved 17 years ago to the States with my husband. So I've been practicing physical therapy for over 25 years now. And very early in my career, I started focusing on scoliosis, and actually not just scoliosis, but kyphosis. So postural dysfunctions. And then I worked with pregnant women and postpartum rehabilitation, but not so a little bit with the pelvic floor, but not as I was not able to do any like internal exam and treatment. So it was more just like focusing on posture, core, and strengthening. And also like having 3 kids, I had 3 sections. So I went through with I had my own struggles sometimes too with pelvic floor and going to doctors, and they were like, oh no, it's definitely not affecting your pelvic floor. So very early on, and I had questions, and I never really got the answer for my questions. And then when I moved to the States, I focused on scoliosis kyphosis because it's a very unique area. Like not a lot of therapists do this in this country. And I started working with a pelvic floor therapist. So we were always in conversation, and I asked her questions. And then she convinced me, she's like, oh, you really should become a pelvic floor therapist because you have such big knowledge and it's all connected. So then I went for my certification, and I'm also a pelvic floor therapist. So these are my two specialties and areas. So I work with pelvic floor and scoliosis and postural dysfunction. So I really focus on these two areas in my work.
So for those who may not know the difference between like a pelvic PT and general physical therapist, can you tell us the difference? Because I've talked about it so much on the podcast, but we may have a new listener who hasn't heard previous episodes and may not know the difference.
Yeah, so a lot of therapists like do general orthopedics. So the big difference with pelvic floor that we do in most cases we do an internal exam. I only work with females, so like vaginal or rectal exam depending on the problems. And then after that, after I determine what is the problem, do they have tightness, weakness, or both, then I also do what I would call more general physical therapy or postural physical therapy. Like I always assess all the muscles and all the joints. So the big difference, like I really examine the person from head to toe, like all the whole structure. So I don't just focus on one area of the body, which I think a lot of people experience when they go to PT, like, oh, my shoulder hurts. Like they're really just going to focus on that one area. So with pelvic floor, we kind of do a full body exam, and then we
Mhm.
specifically also exam the pelvic floor and all the muscles and structures that related.
Okay, thank you for sharing that. And for those who may have not had an experience with a pelvic floor PT, I will say I've had experience, and I know many fear it because they may feel it's invasive. And I find that you all are especially trained in how to be gentle. I have consistently seen that, and I understand it's part of the training as well.
That's like the first part. Like when somebody comes in, a lot of it is education and we talk about it. And because of my other specialty, the scoliosis, I have a lot of patients who actually come, they either have both or they come as a scoliosis or kyphosis patient. And then now, because I'm a pelvic floor therapist, I always ask them questions about their pelvic floor. And often they're surprised, like, why are you asking me those questions? So I have to explain them how it's so connected. And and also because I treat for 60 minutes, I spend 60 minutes with a patient in a private room. We kind of develop that connection, so they start to feel more comfortable with me, and then they open up and ask questions. So a lot of times I actually start treating them as an orthopedic patient for posture, and
Hmm.
then when they understand why they can do certain things, like or they keep having the pain, then I explain it to them, it could be your pelvic floor. And then they go home, they think about it. I explain, like, this is what I'm going to do. I show them the pelvic model. I show them, like, listen, these are muscles, they are inside. You can't see it, but we can palpate and feel the muscles the same way, like we feel your biceps or any other muscle. And most of the time, I really didn't have anybody who said, no, I don't want to do it. So most
Hmm.
people understand and they're really excited. And they're like, oh my God, like changed my life. Like I've been to so many PTs and nobody could unlock or understand. And I love it how you look at the whole body. So it really gives me that satisfaction that my patients do get better and they see the change. Like sometimes they struggle with pain for decades before they find me. So,
And this is why I find experts like you, because I find that's such a theme, is really struggling to find answers. And this is why I love finding the really unique niche doctors because and clinicians, because this is where you're helping people who are struggling. So let's talk about scoliosis. And so obviously from a structural perspective, it's like, okay, if we were to logically think about it, if you have scoliosis, your whole body might just be misaligned. But I'll be honest, like I have scoliosis as well, and I've never really digested the possible impact on my body. And so, why don't you help us educate why it's actually really important to
okay.
understand this nuance? Because I think there's probably a lot more impact than any of us may realize. And honestly, we may not pause to even think, holy cow, I have scoliosis. Here are all these impacts. Please educate us.
Okay. So scoliosis it's a three-dimensional diagnosis. So you have a curve in the frontal plane, or you could have one curve, two curves, three curves, sometimes even four curves. So you see that. And then you also have a rotation in the spine. So a lot of times the way people notice it is like they have that rib hump, or you would see like, oh, why is one side higher than the other side? or sometimes women are like, oh, why is one breast bigger than the other? But it's really not that. It's just because your whole rib cage is rotated. And so one side is protruding, or there's a prominence, and then the other side is like, looks like collapsed, and it's opposite on the two sides. So let's say you have like a right thoracic curve. On the right side, on the back, you would have a prominence, and then on the left side you would have a collapse, and then in the front it's the opposite. On the left side in the front you would have the prominence and the ribs protruding, and then on the right side it would be collapsed or concave. That's how we say it. So, and then also, I mean, most people have more than one curve. So then the lumbar spine, the lower back too, if you have a curve there. So you could have a pelvic shift. Actually, almost everybody has either a rotation or a lot of times pelvic shift, which will just affect your whole structure, just the way you stand, the way you walk. So there's this asymmetry in the body. So on one side of the body you have like tight muscles. On the other side you have like tight and weak. On the other side you have stretched and weak muscles, and it pulls differently. So, but then on the thoracic and the lower back, it's exactly the opposite, right? And then sometimes, so we have these blocks. So we go like shoulder block, thoracic, lower back, and pelvis. Usually it's exactly the opposite. So it's very hard, because when you tell somebody to move, the whole spine moves together. So they kind of have to learn to do corrections, and then but the muscles pull, and the longer the condition is there. So like my clientele is like, I treat from 8 to, I think my oldest patient was like 90. So so kids usually can move pretty easily. With adults, their spine is more stiff. So obviously the body compensates, and then after a while it's like, okay, there's no more, and then that's why they start experiencing the problems, the pain, or the I don't know, pelvic floor issues, or all kinds of symptoms. And the other thing that's very important with the pelvic floor is that the diaphragm. So because it attaches to the lower ribs, and when we breathe, this muscle, right, it goes down and expands, the ribs expand. So if you can imagine that you have this like three-dimensional change in the body, like one side the muscles are shortened, on one side they're stretched out, you will have this imbalance and asymmetry with the breathing. And the respiratory diaphragm and the pelvic diaphragm, they work together. So when the respiratory diaphragm expands and lengthens, the pelvic diaphragm lengthens too. And then when we exhale and the diaphragm shortens, the pelvic diaphragm also shortens. So there's this imbalance with the muscles, which can cause all kinds of problems. And then the other thing, what I like to say, so we're talking about scoliosis, but actually these days kyphosis is another big problem, because we spend so much time on our phones and the computers, so the way we sit. So a lot of people have that forward head and kind of like bent over posture, which puts a lot of pressure on the diaphragm. So the diaphragm gets stuck. So that's another thing I noticed with, I would say, almost all of my patients, unless I had once an opera singer, and very rarely, like really on one hand, I can tell how many patients actually knew how to do diaphragm breathing correctly. So I can say 99% of the patients do not know how to use their diaphragm. If we understand the connection between respiratory diaphragm and pelvic diaphragm, you see why eventually it will create problems in the pelvic floor. I would say the most of my patients would have urinary incontinence. So that's just very common, because they don't use the diaphragm. When they do core work, they use abdominal pressure. Everything, their breathing is off. The trunk pressure management is totally off because of the scoliosis and just the way their body works. So it creates extra pressure. So they're going to have urinary incontinence. Sometimes patients come in because of again, the pelvic shift, they have hip pain. Sometimes they even have leg pain or buttocks pain, which right away, if they go to an orthopedic doctor, oh, it's like, it's your back, it's coming from your back. But no matter what we do from the outside, it just doesn't go away. And then I do an internal exam, and what I find is tightness, because again, the body compensates. One side is stronger, the other side is weak. The glute muscles shut down, they get totally lazy, which stabilizes your pelvis, right? With walking, standing, the glutes are the most important for pelvic stabilization. And then you start compensating with the pelvic floor, and that creates tightness. So there's a muscle called the obturator, and then you have the piriformis from the outside. It kind of sandwiches the sciatic nerve. So I've seen that with a bunch of patients, like they would have like sciatic pain, but you can treat the piriformis or do all those things and it just doesn't go away. And you release the muscle, the pelvic floor muscle, and suddenly they get better. They're able to activate the muscles. We do the postural corrections and they feel great. Sometimes this tightness can radiate into the perineum. So they have issues with sexual intercourse because it's painful because of the tightness. These are the most common, like the incontinence, hip pain, back pain. And then sometimes bowel problems too, a lot of GI issues, constipation. Sometimes if it's stands for a long time, it can lead to fecal incontinence too. I've had scoliosis patients when we worked on posture, everything, they were like, oh wow, oh my God, like finally I can eat, I feel normal, just because everything was so
Wow.
compressed that they were just, nothing worked in their body. I've had, I mean, I, again, these patients were scoliosis patients because for pelvic, I only treat women, but I had, for example, a boy and a man once, like groin pain, testicular pain, and I treated them and I knew it right away. I'm like, it's your pelvic floor. So I referred them to pelvic floor. But again, if they go to an orthopedic doctor, which they do, they're just like, oh, it's coming from your back. And a lot of times it's not. Like you really have to
Wow.
consider the pelvic floor.
And I'm trying to figure out how to phrase this because what is fascinating to me, because I've interviewed so many different experts, is it's all these nuances and how we monitor our body, talk to our doctor in a way that they can most help us, and then finding the right expert. Because, the way I'm doing these interviews to help educate people is really, let's talk about all the potential things that can be happening. And you may listen to this episode and start to ask yourself questions to be able to frame it when you talk to your doctor, but we may always not always know how to frame it. So I'll start that as the preface. Can you talk to us a little bit about what people should be monitoring about their body and noticing, and then maybe like a path of how to navigate this healthcare system?
The way I think about it, it takes time to change the thinking of people. And I do feel like the medical system, it's like everybody's very specialized. So you have to find the right providers who will look at you as a whole and not just a body part. So I think the way it works is just like what you're saying is like, okay, I have this issue, I have that issue, one thing leads to the next thing. And then you kind of put the puzzle pieces together and hopefully eventually you get to the right person. So what I do when I have a patient, I always educate and explain. And I always ask them, I always tell them, like, you have to tell your doctor, you have to explain, you have to educate your friends, you have to educate everybody around you. Like, I know pelvic floor is not an easy topic to talk about. Like, it's not like, oh, my back is hurting or whatever. But if we don't talk about it and we handle it as like a taboo, or it's like, oh my God, like, then it's just not going to get treated. So So I've written to doctors where I had a patient like very, very bad, um, like back pain, radiating pain, and nothing worked. And I did an internal exam and it was very super tight pelvic floor. So I wrote to the doctor. I was like, I think that's the problem. And I got no answer. So, but I did my part. I was like, okay, this is what I found. I told the doctor. So I think it just takes time. And then when people hear about it and then maybe another provider tells them, they put the picture together. So as a listener, I all I can say is you have to be your own advocate and just do your research and think about your body as okay, it's not just one little body part, but it's my whole body and what is affecting what and understand what's going on and try to find the right person. And sometimes you have to go to multiple people until you actually find the right person who will understand your problem and you'll know it, like, because that's my experience with a lot of my patients. They come to me and they start telling me their symptoms and I ask questions like, oh, and do you have this, do you have that? And they look at me and it's like, oh my god, like you're the first person who understands me.
So, one would be hopefully people know that they may have scoliosis. And so, from this episode, they're kind of getting a sense of things that can happen if they do have it. We may come at it from the side of people having some of these symptoms that you discussed, like the GI symptoms, incontinence. Is prolapse also, can that be impacted?
Absolutely, actually, yes, prolapse is a big one. So because of the trunk pressure management, um, a lot of people do have prolapse, especially if they also had babies. Although I have to say, not everybody, like you don't have to have babies to have prolapse. So if you have that trunk
Yep.
pressure management and like constantly pushing down, um, and putting pressure on the pelvic floor, yes, absolutely. And again, what I also mentioned with the kyphosis patients, like they really grip and pull in at the diaphragm level. So I always explain it to them. Just think about it as a like a toothpaste when you're pushing the toothpaste out. Like if you press in the middle, the pressure is going to go down. So that's exactly what happens when you're not using your diaphragm. Like that pressure is going to push down and push all your organs, forcing them down. So that will create the prolapse and all the other symptoms. So when I teach them the pelvic floor contraction and core contraction, I always explain it's like think about like you're pushing out a toothpaste. You have to push it out from the bottom, right? Otherwise, it's just not going to work.
When something like this is getting treated, I guess I'm just thinking about this patient who may be going to all of these different clinicians and struggling with these different aspects. But what I'm hearing is it really is about this root cause. And so, what I'm almost sensing is the pelvic floor is almost the center of it all. And almost everything else radiates from there. So if our body isn't set up to optimize our pelvic floor, so if you have, I guess, scoliosis, hypermobility, et cetera, and this is just absolutely fascinating to me.
Yeah. I mean, I guess because I do so much like scoliosis and postural, like I will tell you, I always start with breathing. So I always start with the diaphragm. I always release the diaphragm. I always teach the diaphragm. A lot of times, the first session, that's all I give patients, and they come back the next session, whether they have weakness, tightness, um, and they are like, oh my God, I feel better. Like sometimes much better, sometimes a little bit better, just because they create that natural movement in the body. So the pelvic floor starts working better, everything just loosens up. So the breathing also has a calming effect on the body, right? So the mindfulness and the body mind connection here is super important. We have so much stress in our life. So just the breathing itself. So I always teach them that and I have so many people, they are stressed out, anxious. I always ask about that. I also have some mental health training in my background. So it's actually kind of sad because I would say 75%. A big, I don't know, I don't have the exact numbers, but a huge portion of the people, kids, adults, have so much anxiety and stress. So just yesterday I had a kid and she was like, I'm so anxious and stressed. And then actually she told me, she's like, can we do some breathing? And I'm like, yeah, of course. So we do some diaphragm breathing, rotational breathing with scoliosis. And then uh, the visual I like to use for them is, or what I like, imagine your head is a snow globe. And this snow globe is like shaken up. Your thoughts are just going. You can't calm down. You can't relax. And just as you breathe in and out, just think about this snow globe kind of slowing down and all the particles resting and relaxing. And people just, everybody just loves that. And this kid yesterday, she was like, at the end she was hugging me and so happy,
Aww.
and she was really like, yeah, just doing everything. So for me, that's where I always start. And then I look at everything else. So I do look at the structure. So with you, I'm not surprised that you have on one side you have pronation and the other side supination and issues, because I'm 99% sure that you put your weight on one side more with your scoliosis. It's unless it's a balanced curve. Sometimes it's a balanced curve and it doesn't happen, but a lot of times one side just gets more tension. So everything you're doing in that pattern, right? So when you're running, you're going to put extra pressure on that foot. So when you go to the doctor, they're just going to look at your foot, but it's much more than that, right? It's not just your foot, it's the whole structure. And then almost everybody who have scoliosis, the spine is just more like, you lose the lordosis a little bit, you have a much flatter back. So when you run, that, the bouncing forces, just create more problems than in your feet and your pelvic floor. So you have to learn, okay, how do I, again, pressure management, which pelvic floor and breathing are just together. You cannot separate the two. So I always look at how people, like, do people hold their breath? How do you do the core? The core is actually very, very important. Almost, again, 90% of the people, when they do core, they do the exact opposite. They hold their breath and want to inhale when they tighten. So they do the opposite, what would be the functional way of doing it. So you're supposed to tighten when you exhale, because that's when the muscles shorten. But most people want to do it exactly the opposite, and they kind of argue with me. It's like, no, I I can't do it that way. I want to do it the other way. So I have to, or I find it, that's another very interesting thing. So I've had this happen to multiple women when I'm like, okay, uh, let's see what happens when you tighten and when you do core. So I ask them, okay, tighten, bear down, and they do the exact opposite. I'm like, you're bearing down when I'm asking them to tighten. And they're like, no. So they actually argue with me. I'm like, no, I'm tightening. I'm like, no, you're not. I'm like, I can feel it. And then I ask them, I'm like, okay, show me how you do the core. And then I see their belly protruding, coming out, and like they're pushing down. So it sometimes takes a lot of convincing to so they believe me. I'm like, you're doing the opposite what you need. So we have to work from the feet up, and the feet through the fascia, everything is connected. So for you, the feet, like how you're grounding yourself, like how you're engaging everything. So I put the pieces. So first I take the pieces apart, right? Your diaphragm, your pelvic floor, your feet, the different blocks in your body, your posture. I teach you all the pieces, and then we put the pieces back together so the body can work then in harmony together and correctly.
What you haven't said, and so what I'm gathering is you don't necessarily need to fix the scoliosis, correct? Because you can't necessarily, I mean, I know that there are people who've had procedures done, but generally speaking, you haven't mentioned anything about we have to change it. It almost seems like we're trying to figure out how to make your body work with what you're dealing with. Is that a fair summary?
If I have a patient who has hypermobility, there are pros and cons. So you can do better corrections because you have more movement in the spine, but you have less stability. So with you probably I would need to work on more stability. And when you have hypermobility, certain muscles will be tight because it's trying to hold things together. So you might feel like, oh, like I need to stretch my hamstring because it feels good, but you may not need that. So, like, I would probably tell you, like, okay, maybe roll it or do other things, but you're already so stretched and hypermobile. You don't need to stretch more. You need to stabilize it. If I have somebody who's very stiff, they will not be able to do a lot of corrections because they just don't move. So
Right.
maybe I have to do a little more manual work on them, stretching, loosening things up so everything kind of frees up. So with with kids, you can do a lot of corrections.
I bet.
With adults, it's I always tell them the goal is not to fix your scoliosis. Even with kids, like we want to slow down the progression. We want to make them stronger. But with kids, you can decrease the curvature sometimes, but not always. But with adults, it's really just to give them a different stability. So the way I always say is just imagine you're always doing everything in your curve. So when you sit, I look at you. So let's say, I don't know, you have a curve, and again it depends on the curve, but let's say you always sit on your left side because the curve pulls you to the left. Then I teach you how to put equal weight on both sit bones and just sit up a little bit straighter. When you're standing, I point out, like, do you see how you're standing? So we do the easy positions, and then we go more functional, like moving arms, moving legs, doing squats, because we have to bend, we have to pick up things. So I start doing more functional, or somebody who is, if they do certain exercises, or you're a runner, so I would work with the exercises that you want to do. And core is actually also a very interesting thing. So I mean, I also teach them what not to do. So crunches, right, when we bend forward, that increases the curvature, so you don't want to do it. So we want more neutral spine. So what's interesting with the core is when you have scoliosis, there's always rotation in the spine. So when you do like a marching. So you're lying on your back, and I ask you to engage, lift one leg, right? And keep your pelvis stable. There's always rotation. So one side of the pelvis drops. And so you're always strengthening into your curve, right? So sometimes I use passive corrections, or I just teach the persons, like, okay, stabilize and make sure your pelvis does not pull you into your curve. So it's a lot of mental work for them. And then, of course, because we were talking about pelvic floor, right? Like, let's say you had weak pelvic floor, then I would also first teach you to engage through the pelvic floor. So I kind of monitor it to make sure you're not pressing down, and also do the nice diaphragm breathing and engage through the pelvic floor. And then once you can do that, then we go into the harder exercises and the more functional exercises. So because when you run, you can run in your corrections, right? But you train your muscles to activate better, um, and more balance. So when you're walking, when you're running, you're in a better position. So that's the goal of the treatment, right? So you're not stressing not over stressing one structure, and and your all the muscles are active. Like and working, like your pelvic floor is active, your core is active, your glutes are active. So because we sit so much, the glutes shut down, then again, then maybe the pelvic floor muscles take over, and then you have tightness because of that. But I always say, if I have a tight bicep, it doesn't mean it's strong, it's actually weak. So if I put like a bag and I was like, okay, hold it, you wouldn't be able to hold it. So the same thing happens with the pelvic floor. So like
Okay.
you're running, and then and the pelvic floor cannot hold anymore. So you could have
Okay.
that tightness, like, right, you're not using your diaphragm, things are not working correctly, then you may become, you may lose urine or even bowel movement. So
Interesting.
because the muscles are just not working.
I'm assuming that a lot of these patients, like there's certain exercises that are just pure torture. And that could possibly be a sign, and not torture necessarily painful, but just like least favorite, right? And maybe those are also hints of what could be going on. Would that be a fair assessment?
Absolutely, it's uncomfortable. Like, actually, the way I explain it to my patients, when because I get very excited when they do a good correction and they're doing exercises right, and I always explain it to them like, I know it feels to you. So somebody who doesn't have scoliosis, I always say like, okay, create a curve and not do everything like that. And I could be telling you, like, not you're straight, you look great. Okay, stay like that. And they would be like, okay, you're crazy, lady. I cannot do this. That's how it feels for somebody who has a postural dysfunction, kyphosis or scoliosis. When they are straight, their brain is telling them, like, no, 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 this is not okay. Like, this is not straight. Like, I can't. So it's very, very hard, and they're going to fight it. And so I do, especially with kids, I try to distract them. So I talk to them, I'm like, tell me what you had for lunch, or I make them count backwards, and then they lose the correction, they do nothing, and I'm like, I'm still watching you, you have to maintain your corrections. And then it's just so interesting, you distract them a little bit, but with adults too. So I talk to my patients a lot, and then I watch them. And then, I mean, if you've been coming to me, you know my tricks, but I'm always like, you still have to be in your, like, try, because in our daily life, we multitask, we don't just do corrections. And the other thing, it's like rewriting the program in your brain, your neuromuscular system. Like, you have to learn a new pattern. So getting rid of these maladaptive patterns takes a long time. It
Yep.
can take 6 to 12 months. So people have to be patient. So again, depending on the diagnosis and what's going on. I mean, I've had patients who, like pelvic floor, who got better after a few treatment, but then if we add the postural component to it, it definitely takes longer and a
Hmm.
lot of practice, and the being consistent with it, because it's better to do 10 minutes every day than do 1 hour or two
Yeah.
hours on Saturdays,
Yeah.
because you have to get rid of these patterns, and it's really hard to get rid of the patterns. We don't even realize that we are doing it. So it's a lot of it, and it's painful because it's, crossing your leg. That's really not good for you, because you're twisting, and it's not good for your pelvic floor or the way you sit. Maybe you have tightness, maybe you have tailbone pain, like I had that too with patients. And then the way you sit, so you have to figure it out. Like, I always tell people, like, do little post-it notes or set an alarm, so you remind yourself, like, okay, like, reset, and eventually it will work. But it's painful, like
Yeah.
what you said. In a way, it's hard,
Yeah.
it's mentally exhausting to do
Right.
it.
But it's worth it because, let's tie back to the symptoms. And so, I know that when I originally started interviewing pelvic floor experts, um, one of the things is there's so many preventative measures. So, for example, if you're pregnant, visit a pelvic floor PT before you deliver the baby, because even that visit can help minimize things that can happen during delivery or after you've had the child. And what I'm almost hearing is, there are these really frustrating and sometimes really bad things that can happen if we aren't proactive and if scoliosis is a contributor to pelvic floor issues. So, in the grand scheme of this, is this now another thing? Like if someone were to be formally diagnosed with scoliosis and they knew that, would you say that it's probably important to start learning how to correct it so that in the long term we don't have these
So
issues?
so I always say it's always worth it to take a look, because I always tell also patients, especially my adult patients, that the body is actually amazing at creating balance. And sometimes I work with patients who have a lot of instability. So the scoliosis, because of the curve, can create movement like to the side, like they have that instability that one vertebrae moves sideways or forward or backward. So, and that's the source of the pain. So, and sometimes I look at the x-ray and I'm like, wow, like if the patient has no pain, they just don't like how they look or whatever, then I'm a little more careful of what I do, because I don't want to move them and then create a problem, because the body actually created a balance. So the patient is pain free. And women, we tend to be holding. I don't know if it's like we just want to be skinny, or I don't know what it is, but women always hold. They're like, they ask me like, oh, should I always hold my core tight? I'm like, no. Just breathe. And I always tell them like, just trust me, just because you breathe and your belly comes in and out, I promise you, you're not going to have a bigger belly. It's actually going to be like less. But I don't know, I noticed that with women a lot, they hold, and again, that will eventually affect their pelvic floor.
The pelvic floor is a bigger deal than I think any of us have ever imagined, and it's just really fascinating to talk to you all and to just realize how important it is to get it stable, because there are long-term impacts if we don't. But it's and this is not a doom and gloom. This is great. It's just like, if we know we have these issues, just go visit a pelvic PT and just at least get an exam to have an idea of what's going on, is kind of what I'm taking away from this.
Exactly. It's kind of like, because we don't see it and it's an intimate part of us, I think we tend to ignore it and people are embarrassed about it. So we have to get over that. Like, no, it's muscles, and you have to treat it the same way as you treat any other muscle. And because I always say, like when I teach posture too, it's like I call the pelvis is like as the base of our house. So the pelvic floor is that support on the bottom. So yes, if something is off, then the pelvic floor is going to be the first structure that gets affected. So and women, we really have to step up and talk about it and not be embarrassed about it, because you can you can treat these problems. And when you have, yes, a hysterectomy or any surgery. I mean, I've had patients who had sling surgery for prolapse and they still had problems and nobody told them to go to pelvic floor PT. We have to like basically just educate, talk about it, and not feel embarrassed about it. It's part of our body, and it's very important.
Absolutely. Yeah, my conclusion from this is we need to have a primary care doctor, an OBGYN, and at each life stage visit a pelvic PT. Like seriously, right?
Yes.
I mean, that's the conclusion. So hopefully our healthcare system will start reimbursing clinicians for that and make pelvic
I,
PT part of proactive care. I mean, it is just an unbelievable specialty.
and like the education also has to change. I mean, I'm sure you've heard it from other providers, and I know menopause and perimenopause is a hot topic now, like how doctors, OBGYNs, they're just not trained.
Yeah.
So they don't even know, they're like, well, it's menopause.
Yep.
And so they really don't guide you. Nobody really prepares you. So it's definitely, there is a big gap. and and I mean, I'm hopeful because I feel like women are more proactive, and I do see the change. But it has to be, yes, like insurance, it has to be covered by insurance. It
Yep.
has to be something that's just offered to every woman without any question.
Yeah, no, exactly. Exactly. Well, this has been wonderful and I really 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 appreciate you making time to educate us on this topic. It is something that was new to me and I think it's going to be helpful to so many people. And it was so fun to interview a fellow Hungarian.
Yeah, thank you. I'm excited. Yeah, I was very excited. Thank you so much. This was a pleasure for me too. It's exciting to share all the the wisdom and the thoughts.
And that wraps up another empowering session here at the Fempower Health Podcast. Now, before you dash off, I've got a quick, exciting invitation for you. Please join our vibrant community by subscribing to our weekly newsletter because it's really your frontline update on groundbreaking women's health research, the latest health enhancing products, fun quizzes to boost your health IQ, and unique discoveries that you won't want to miss. All of this delivered straight to your inbox, cutting through the noise of social media algorithms. Love today's insights? Show your support by rating and reviewing our podcast. Your feedback is more than just a pat on our backs here at Fempower Health. It lights the way for others seeking guidance and community in their health journey, amplifying the voices that need to be heard. And for a deeper dive into today's topics, check out the show notes and explore our website at fempower-health.com. Our site is a treasure trove of knowledge, neatly categorized by topics of interest and life stages, ensuring you find exactly what you need to empower your health journey. And your voice matters to us deeply. Whether you have a question, a story to share, or feedback on our episodes, reach out directly at info@fempower-health.com. Drop us a message on social media or hit reply on any newsletter. Your insights inspire our conversations. And a quick note, the knowledge we share is here to embolden you in discussions with your healthcare provider. It's not medical advice. Always consult with your doctor for health decisions. And remember, the diverse perspectives of our guests reflect their individual journeys, and it's not an endorsement by Fempower Health. Here's to empowering your health journey one episode at a time, and I'll see you on the next Fempower Health Podcast episode.